Welcome, everyone. I'm Amanda Egan, the Director of Patient Engagement and Clinical Programs with the RUNX1 Research Program. I'm so glad you could join us today for our webinar, Sirolimus Pilot Study Update, Investigator and Patient Perspectives. We're excited to share that this study has now been open since July. And today we'll be hearing from one of the study leads about its purpose, who is eligible to participate, and what patients can expect if they choose to enroll. She'll also provide a brief look at what the team is seeing so far, from the first few participants. And then following the presentation, we'll take some time to answer questions from you all, from the audience. And then we'll shift to another section where we'll be joined by 3 individuals living with RUNX1 FPD who have personal experience taking sirolimus. So we have that first part for the first half hour where Dr. DiNardo will be speaking about the trial and the experience so far. And then that second part, we will have 3 patients joining, a couple of them officially part of the study and a couple of them participating sort of remotely by taking the drug. So we'll leave time for you to ask questions of the patient participants as well. So throughout the webinar, please feel free to use the Q&A icon to type in your questions at any time. You'll see that at the bottom of your screen. We'll begin addressing them after each part of the presentation. So if you prefer, you can actually submit questions anonymously. There'll be a box for you to check. Either way, only the speakers and myself can see who submitted the questions, and I'll read them aloud without identifying anyone's specific personal information. So we encourage you to ask anything that's on your mind, no questions too small. And just a reminder, if you would like to explore your individual health status and eligibility, we are glad to connect you to the team later, as they answer questions, they won't have the full picture of your health today to really provide a comprehensive answer. So now I'm pleased to introduce Dr. Courtney DiNardo from MD Anderson Cancer Center in Houston, Texas, who is actually currently joining us from Latin America. So bear with us if there are any reception difficulties. Dr. DiNardo is the principal investigator for this study. She's a nationally recognized expert in personalized therapies for AML and leads numerous clinical trials focused on advancing treatment options. So she's also a longtime advisor to the RUNX1 Research Program through her role on our scientific advisory board. Dr. DiNardo, I will turn things over to you now. As you know, Catherine's managing the slides, so you can let her know if you want her to advance, and then I will hide myself and return after your talk.
Perfect. Well, thank you so much for the introduction. It is my pleasure to be here. And as mentioned, I am currently at the ASH Highlights of Latin America meeting, so I do apologize if there's any kind of background noise. I tried to hide myself in a room that I think will be safe, but apologies in advance if we get interrupted. And actually, just as a little caveat, I will say that my talk here is on AML, but yet the number of questions I had about inherited heme malignancies and cancer syndromes, it really, I think, the recognition of kind of the fact that there are these RUNX1 is one of the cornerstone diagnoses within this, I think, increasingly aware area, I think is just more and more an important topic of conversation. So it was really gratifying to get some of those questions. All right, so today we'll be talking about the Low-Dose Sirolimus Pilot Study that is open and enrolling here at MD Anderson. And I want to provide just a few slides of background information about why in the world we are using sirolimus for individuals who have germline RUNX1 FPD. So we know many people for decades have been researching, and Dr. Anupriya Agarwal, mentioned a few times, is really one of the key scientists involved in this study and this data, that having RUNX1 FPD is associated just at baseline with elevated levels of inflammation, primarily in the bone marrow. It has been kind of identified that the stem cells, the hematopoietic stem cells in individuals with RUNX1 FPD have these elevated levels of inflammatory signaling markers like PI3 kinase, but especially mTOR. And these chronic elevated levels of inflammation is thought to be one of the key mediators of future cancer development, this chronic kind of inflammation picture. And so the question, of course, is, can you lower this inflammatory, paradigm and thus decrease the risk of future cancer development? And can we do that with kind of effective agents that we know will reduce these inflammatory proteins? Next slide. So this just highlights the rationale in a more kind of figurative way, where, you have these hematopoietic stem cells, and here we're looking, these blue circles are a healthy individual with RUNX1 FPD, and you have this increased pro-inflammatory protein development, these yellow triangles. And with time, the thought is that these increased yellow triangles, this inflammatory signaling milieu, is helping to create these precancerous stem cells, and ultimately that is potentially what may develop into blood cancer stem cells, down the road over a period of time. And so next slide. So just again highlighting and maybe being a little bit more specific in terms of the rationale. So, as many of you probably are aware, that patients, individuals who have RUNX1 FPD have a higher baseline diagnoses of different inflammatory conditions, autoimmune diseases, allergic conditions, eczema, and that seems to be related to this hyperinflammatory, these inflammatory signaling proteins and altered immunity, which seems to really focus through the mTOR pathway. And highlighted in number 3 here is that we have mTOR inhibitors. There are drugs like everolimus and sirolimus that have been available and approved for decades now. And it seems, at least in the lab, what Dr. Anupriya Agarwal is highlighting is that using these inhibitors can help suppress and reverse this inflammatory phenotype that develops in individuals with RUNX1 FPD, at least in the lab, right? And so, we have that information. We also know, as in number 4, that when you're using sirolimus or mTOR inhibitors at high doses, it can be used to prevent organ transplant rejection. These are very commonly used in people that have had lung transplants or liver transplants. And there are multiple other studies of looking at lower doses of these mTOR inhibitors. The one highlighted here is low-dose sirolimus for 6 months that was used to and identified to reduce colon cancer size, polyp size, the number of polyps, and the actual PK sampling looking at mTOR signaling. It was suppressed in patients who have a colon cancer predisposition syndrome, something called FAP, where they are born not with an increased risk of myeloid malignancies, but an increased risk of developing colon cancer and multiple colon cancers through the development of polyps in their lifetime. Next slide. So this is, it's an overwhelming figure, but it's meant to just highlight the fact that there's a lot of data that we know about mTOR inhibitors. This has been something that, these agents have been around since the 70s. And we, as we've, become more advanced and have more kind of understanding of these molecules, I think we appreciate more that what we used to always call an immunosuppressant is really, I think, a little bit misleading. These are not immunosuppressants that are, I think, going to give people higher risks of certain kind of infections or things. These are really immunomodulators. I think that's a more appropriate term, as is highlighted in the second bullet here. And it really does seem to have kind of inhibitory properties of these kind of aberrant growth signaling in some people. There's also a whole backstory, which I don't know how many of you are following it. I hadn't until I had gotten involved in this pilot study. But there's this whole kind of separate story of people using sirolimus and everolimus and other mTOR inhibitors to decrease cancer incidence kind of across the board, and also to extend lifespan. It's kind of a longevity drug that's being repurposed, which I think is a little bit outside the scope of this talk, but very interesting that that it's kind of getting a second life as potentially a longevity agent. Next slide. So the question for the pilot study and what we're all on the call for today is kind of a discussion of, can sirolimus improve blood counts and reduce the risk of blood cancer? Next slide. And here is the slide I was kind of talking about earlier, where you have sirolimus treatment, that kind of blue medication, where it's kind of halting and stopping that the pro-inflammatory proteins that are just part of the bone marrow niche, part of what happens in individuals who have RUNX1 FPD. And so hopefully putting a halt on those kind of orange precancerous, pre-leukemia stem cells that can develop that seem to be revved up by these pro-inflammatory proteins. Next slide. And so this is kind of highlighting what we hope is going to be the case. You're stopping the development of those and really just kind of trying to keep the bone marrow and the hematopoietic stem cells kind of in a more natural, less inflamed situation to improve the overall health of the blood system. Next slide. So now we'll go into a little bit more detail about the pilot study itself. Next slide. And, one of the questions actually that gets asked to me a lot is, what is a pilot study? Like, what do we mean by a pilot study? And so I thought this is a helpful slide to just explain what a pilot study is. It's essentially a precursor trial to a larger study, because what we're trying to do is really define, we have a drug and we know it's safe and we know it's FDA approved already in other kind of populations and other disease types. And so we're not so much needing to start in a phase 1 or even a phase 2 because we already kind of know the drug and what we're doing. What we're trying to figure out is, is it safe and effective in a different population? And are we seeing what we want to see? Do we know what the right endpoint is as we move this into, a larger, more potentially like registrational clinical trial. So the pilot study is really there to build evidence that, does this make sense? Are we seeing a signal? Should we move forward into, a larger confirmatory trial? Next slide. And so for those of you who may be affected with RUNX1 FPD and are thinking about whether or not they want to be joining this study, these are, I think, questions to ask for any clinical trial, whether it's related to RUNX1 FPD or not. I mean, I think these are all really important questions to be asking. Is this something that you are motivated to participate in? Is the research of interest? Is it relevant to you? Of course, do you meet the eligibility criteria? Do you have, the RUNX1 FPD diagnosis in question for this pilot study, of course? Are there benefits for this? What are there risks and what are they? And, are the benefits worth the risks? What logistical factors should I consider? This is something I assume we'll talk a little bit about that are certainly important when it comes to trial participation, and other questions or concerns that may be unique to you and your situation that need to be addressed for you to feel comfortable or decide one way or the other about participation. Next slide. So the primary objectives, as mentioned, for this pilot study, we're really just trying to make sure that this is kind of a safe and well-tolerated therapy for individuals who have germline RUNX1. And it is specifically for people that have not developed any sort of myeloid or any hematopoietic malignancy, I should say. The secondary objectives are many. We're really trying to learn as much as we can from the small number of patients that will participate in this pilot study. We want to evaluate bleeding symptoms. And so there are questionnaires about bleeding risk and number of occasions and things of that sort that are asked. We are monitoring clinical laboratory changes, both standard CBC criteria, of course, and also fancier bleeding tests that are samples that are being sent to Boston. We're also measuring markers of bone marrow function, looking at inflammation. Exactly what we're trying to do is kind of suppress this abnormal inflammation process. So look at bone marrow samples before and after we are starting sirolimus and seeing what's changing. Of course, like the platelet precursors and white cell precursors and blast, all those things are in the standard bone marrow that we're looking at, but we're also doing fancier tests too, looking specifically at many of these inflammatory proteins like mTORC1, and also, down the cascade and seeing what is changing and what's staying the same. Is it doing what we think it should be doing? And as well as assessing changes in patient-reported outcomes, not just bleeding questionnaires, but also a questionnaire about just kind of quality of life and different aspects of life in general before, during, and after, and have things changed in any significant way. Next slide. So a couple specifics about eligibility. So you need to be an adult, 18 years of age or older, and you do need to have a platelet count 50,000 or greater. You can't have any major organ dysfunction. And if anyone has, it needs to be fairly major to be an exclusion criteria, but certainly something we could discuss in more detail if anyone has any questions there. You don't want to be pregnant while participating. You do need to have a confirmed either pathogenic or likely pathogenic germline RUNX1 variant. And so that is something that is defined by the ClinGen group, and we can talk more specifics if you have a specific RUNX1 variant in question. And there are certain medications that can interact with sirolimus, so we'd want to make sure you weren't on any of those where we're not sure the sirolimus levels that you could be actually accumulating in your body. And so we would want to make sure you weren't on any kind of medications that could potentially interact in a negative way. Next slide. So the trial is it's a 6-month intervention trial. So you come to MD Anderson, you have a couple pre-screening lab tests and a bone marrow prior to treatment start. You can do that anytime within a month before starting. And then you start treatment and you stay at MD Anderson for really the first week for the most part, because there's labs when you start on like day 0 and then labs a week later just to make sure you're tolerating the sirolimus okay. And those usually are done at MD Anderson, but as you'll note, it says at the 1-week mark, we've kind of tried to make things as logistically simple as possible. It's not easy because there's so many kind of fancy tests that we're doing that have to be collected at MD Anderson, but any of the labs that are just standard, CBCs and organ function and chemistries, we allow telehealth so people can head home. And so you start your treatment at MD Anderson. Many people stay that first week, or you can head home, and as long as you've got kind of the ability to get lab work at home, then you have an evaluation at the end of the first month. At 3 months, which is the halfway point, there's also a 5-month mark, but a telehealth check-in is okay there. And then at the end of treatment, which is at the 6-month mark, where we do a bone marrow there. So you've got the before, you've got the end of treatment bone marrow at 6 months. And then there's a follow-up at the end of a year at MD Anderson with kind of a final evaluation. We check the questionnaires again, and there's one final optional bone marrow at that time point. And otherwise, it's a daily pill, sirolimus, that people are taking. So we have kind of these little like diary calendars, and you just kind of mark off that you took it on any given day, and it's self-administered. Next slide. The most common side effects are listed here. Certainly when you look at, I say this to people that see me in clinic, my patients all the time, any side effect profile is really intimidating. You look at, your Tylenol that's in your drug cabinet, and it's a terrifying list of side effects. Almost everyone will have 1 or 2 side effects of any given therapy, but exactly how that will affect you is, of course, a little bit harder to know and to predict. But the most common side effects are listed here. Abdominal GI-related side effects are the most common. So it can be constipation, it can be diarrhea, it can be nausea, but usually something in the realm of GI. At higher doses, sirolimus is associated with kind of higher cholesterol levels, higher triglyceride levels. So we do monitor that. That isn't something that we have seen at these lower doses that we're using. Fluid retention, headaches, muscle aches, changes in blood counts, and blood clots are all listed as the most common side effects. Next slide. And then, just speaking specific to, there have been 2 patients that have been, one is still in the midst of the 6-month sirolimus pilot project, and one has completed the 6 months. And so what we've seen so far in these 2 individuals has been that there does appear to be improvement in actual platelet function in the lab-based assay that we are doing. There have been some evidence that the white cell count, which is not the platelet count, but the white cell count, which was a little bit lower, can actually seem to normalize with kind of healthy looking myeloid cells. Stable stem cell clones in the time points we've evaluated so far, there hasn't really been a significant change in the clonal architecture of the stem cells that we've looked at. And quality of life is kind of interesting because it shows that there have been some things that seem to improve, like joint pain in particular. Also, like something that hadn't been, or at least I hadn't discussed much with a participant, but looking at the questionnaires over time, a significant improvement in kind of baseline anxiety, which I thought was interesting. Improvement in like allergic type symptoms and weight loss in one patient, which may be related to feeling healthier and having fewer joint pains, or maybe related to the side effects that person was experiencing, which was kind of nausea and abdominal pain, unfortunately, and so maybe not eating as much potentially. And so there, you will hear from some of these participants a little bit later. So for those who are curious, I would encourage you to kind of ask them in a little bit more detail. There is an association of sirolimus at higher doses with mouth sores, and that was something that was experienced and described by one participant. So something that we're now kind of talking about as a more realistic side effect. Headache, urinary tract infections, and hemorrhoids were described, which are, again, things to discuss with the participants over the next sessions. There's certainly nothing what we would call drug limiting, but I think it's safe to say there will be some side effects of any type of treatment. And so these are the things that we have seen, but some really quite encouraging things on the flip side of, how this may be impacting in a positive way, the bone marrow. Next slide. Oh, and that is the end, actually. So I will pause for a second and see if anyone has any questions for me specifically, and then we will pivot to the participants.
Thank you. Okay. Well, thank you, Dr. DiNardo. That was great. Really good I think it was last July or August that you presented some of this before, and it's really nice to see the positive outcome so far. And yeah, and the reality, I'm sure patients will be excited to hear from others a little bit more about their experience. Okay, so everyone that's on the call, feel free to drop in questions into the Q&A icon if you have any. I do have a couple here that people submitted ahead of time as well. I can kick off with. So you mentioned there are 2 patients so far. And so someone was curious about how many patients are still needed to complete the pilot study itself, and then what are the planned next steps beyond the pilot?
Yeah, the pilot study itself is only enrolling a total of 6 patients. So it actually, I'm a little bit surprised we haven't enrolled faster. I think some of that is just because, being part of a study when you are healthy, living your life, and, having to travel to Houston is, can be a little bit of a logistical challenge. But yes, so there's only 4 more patients that are required to kind of complete the initial pilot study. And then we take a pause, we look at what we've seen, we decide, does this make sense to kind of build out further in a more like multi-institutional or registrational approach. And that'll be something that I know, Amanda, you'll be kind of really heavily involved in as we kind of make that decision.
Exactly. Okay, great. Actually, so 2 points that you just made, I'd like to expand on, and they're related to questions we got. So someone was asking, what if I feel great is it worth pursuing this trial for someone who's feeling, they know they have a variant in their RUNX1 gene, but virtually feel no disruption day to day in their lifestyle? What are your thoughts on that?
I mean, I think it really just depends on where your head is at. I feel like there are all sorts of different people in this world, right? And some people feel like they really want to do something. And so participating in a pilot study like this, if you have a familial RUNX1 FPD, I think is a great option for someone who feels like they really want to help advance the field and really get a sense of like, is sirolimus something that can be helpful, maybe for me, maybe for other people in our community moving forward. So I wouldn't say don't participate if you're feeling well, but I but it does, when we talk about risks and benefits, if you have no baseline symptoms that you're trying to improve, it does make, that potential risk a little bit higher. So that's part of the decision that you need to make. But I, again, will hopefully reiterate and say that I think people, tolerate low doses of sirolimus pretty well. So if it's something someone's interested in, absolutely reach out, to the RUNX1 Foundation, reach out to me, and I'd be happy to talk you through it a little more detail.
Great. Yes. And actually, I think maybe we can see if Tim, Jill, or Trista want to speak to sort of their thought process before they started taking sirolimus. Oh, sorry. We'll get to you, Tim. Or actually, if you want to comment now, you can about your.
I'm happy, Amanda. I didn't know if
Okay.
you were asking me to get online.
Yeah, sorry about that.
Whenever you're ready.
you were ready, and you were listening for your name. Thanks. So yeah, we'll shift to them in just momentarily. But okay, and then the other thing you had mentioned was logistically, if expecting that we would see quick enrollment. We certainly have. We have spoken to many patients who are very interested and have had different reasons why they are not ready right now to participate. And certainly we've heard a lot of concerns around logistics and then cost. And so someone was asking, I understand. So actually, let me first say, I think everyone knows, but if you don't, we have already, at RRP, we have committed to helping cover the travel. So there are some appointments that require traveling to Houston if you don't live there. And so we are covering flight, hotel, and some food costs. And then people have been also asking, well, okay, I know that a lot of the tests and procedures are covered by the study, by the sponsor, which is RP. But also we know this is going to hit insurance. And so people are luckily very in tune with how their insurance works and knowing there's copays, deductibles, co-insurance to consider. So people have been asking how can they reduce costs and they're concerned in that area. So I just wanted to share with you all today that we have been working really closely with our board to discuss this. And so we haven't finalized the specific details, but RP is prepared to cover the majority of out-of-pocket costs like those, like the copays and co-insurance after your insurance is applied. So we don't have the specifics just yet, but please, if you're interested in participating and you're concerned about cost, please reach out to me so we can talk through those details to help you participate if you'd like. Okay, that was a lot from me. Let's see, another question for you, Dr. DiNardo. I'm looking at the time. So we have a couple of patients who've been thinking about whether it's suitable for them. So one was asking, is the trial suitable for patients with MDS who have not responded to other medications? What are your thoughts?
That's the short, easy answer is no. There's just no real data of effectiveness here. Once someone has already transitioned to a heme malignancy, so kind of more standard treatments, I think would be what we would recommend in that situation.
Yeah. Okay. Sounds good. And then, do you have your sights set on like knowing one day down the road if this would apply for someone with a malignancy? Or are we really thinking about this as a prevention treatment for RUNX1?
My suspicion is this will be more of a preventative, potentially more long-term maintenance type approach. So I think, the pilot study is looking at sirolimus for 6 months, which is a very kind of reasonable thing to do because you can't, do studies for years and years and years, because then you're just waiting a long time to get answers. But I think in the future, it will potentially, in people who are tolerating this well, and we're seeing this suppression of kind of this abnormal immune phenotype, to do it for a longer period of time. But I'm not sure about how effective it would be in patients that have already transitioned to malignancy. So I'm just not as sure. Dr. Agarwal is on the call. I see she's one of the attendees. I don't know if she has any particular insights there that I'll give her the opportunity to kind of mention if she wants to.
I will.
But she might not be able to as an attendee, right?
Let's see. Actually, she's there. I see her name. Dr. Agarwal, are you able to unmute? I can't tell.
No.
Hello?
Oh, there we go.
Great question. As Courtney said, I don't think we are prepared yet, but we are testing, like we created a mouse model, which mimic some secondary mutations along with RUNX1, and we are testing sirolimus sirolimus in those models. So I'm sure in future we can answer that. At this point, we don't have that much data to answer that, like to suggest sirolimus in those patients.
Okay, that sounds good, but maybe down the road, it could be something we can look at. Okay, great. Thank you. Thanks for hopping in. Okay, so we have another one. Let's see, can those with additional somatic mutations in addition to the germline RUNX1 be eligible? Yes.
Yeah,
Do you have a
absolutely.
list?
And that has been the case. And it just depends on how deep the sequencing we're doing is. Almost everyone, even people without germline RUNX1 are going to have somatic mutations in some of their bone marrow cells. And so I think it's going to become more and more a reality that we're seeing these a lot. The official definition is a VAF of 2% or higher of one of the CHIP genes, and so that is a little less frequent, but still very much eligible to participate. And that's kind of a key question for me as we're following patients who have those smaller somatic mutations. Does it change in any way? Are we, seeing one of those smaller clones disappear or decrease over time?
Yeah. Okay, great. And then another question there is this study open to international patients?
Yes, but anyone, of course, we would want to be able to participate, but at present, the study is only open at MD Anderson. And so things do go through insurance that are not covered by the study, which is kind of a lot of the standard things. So trying to do that when you don't have US medical insurance is going to be expensive. And probably not realistic.
Yeah, and that's another thing we've been sort of on our side trying to work through. Are there options for obtaining international insurance? And so far we haven't found a perfect solution, but if anyone wants to reach out to us, we can let you know what we're learning and brainstorm ideas for you if you're really eager to participate. Certainly want to help with barriers, eliminate barriers, certainly if we can. Okay, why don't I ask you one more question and then we will let you back to it because I know we're a little bit past the half hour. So which one was so how about this? So is it the case that if someone is experiencing, okay, so we've talked about side effects, right? And so there's concern about, these side effects and some others, and we don't know how it's going to behave in an individual. And I think some are concerned about how will it behave in their body. So are there opportunities for patients to stop taking the medication if they're experiencing side effects that aren't,
Absolutely. So if anyone has an intolerable side effect, we do not force someone to stay on a medication they're not tolerating well. We certainly would try, see if there's a side effect that's causing, heartburn, for instance. We can help with heartburn medications. If there's headaches, we can help with headache medications. We of course want to try give, the therapy a chance to do its thing. There's also the opportunity to dose reduce. We start at a low dose, but it can be reduced by 50% even so. So those are all things we could consider doing. But yes, if someone is not tolerating it well and doesn't want to continue, we would stop.
Okay, thanks. I guess on the flip side, this is a 6-month trial. So what if, we saw the benefits that patients are seeing. So what if they want to continue? Is there an option, or how are you discussing that with your patients?
Yeah. So that it's case by case each time. I think, the pilot study itself will be over after 6 months of treatment. But if anyone, is saying, that longevity piece of it, like I'm feeling better, whatever symptoms I was having are improved on this, and I would like to continue it, I absolutely would be kind of happy to discuss with them continuing it as like a standard of care and not on a trial.
Okay, perfect. Okay, thank you, Dr. DiNardo. I really appreciate you taking time away from afar, and I know things are busy there, and but we really appreciate all you're doing. So your commitment to the patient community is really, really appreciated. So take good care, and I'll let you hop off if you're ready to get back to your talks, and then we'll shift to this next
Unfortunately, I do need to run, but thank you very much. It's my privilege to be part of this. It's a really important thing. So yeah.
Thank you. Okay. Talk to you soon. Take care.